National Anthem Negaraku. Hello and good morning. Welcome to the MAHSA International Pharmacy. We would like to continue the session with blessing from the Almighty. We would like to invite Dr. Sohail to lead the Dua recitation and a moment of silence.
Bismillahirrahmanirrahim. Ya Allah, Ya Rahim. Praise be to Allah, the Lord of the worlds. Peace and blessings be upon our Prophet Muhammad sallallahu alaihi wasallam and his companions, and for those who followed his example till the judgment day. Allahumma ya Allah, on this blessed morning, in conjunction with Mi-PHARM, we beseech thee and grateful towards you in favor of all the infinite blessings to us, your humble servant, to live in safe and prosperous life. We seek your blessing for the flawless progress of this event from the beginning till the end. We seek your guidance to steer clear of events that would detrimental the progress of this event. Ya Latif, Ya Rahman, please bless us with your tawfiq and hidayah. Please guide MAHSA University to greatness, peace, glory, and prosperity in this world and hereafter. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين آمين.
Thank you, Dr. Sohail. May our event be blessed and run smoothly. Welcome to the first MAHSA International Pharmacy Mi-PHARM Conference 2021. As customary, we may start with a Malaysian welcoming poetry. Melayang serinde di atas permatang, merba berkicau di hujung muara, pemanis kata selamat datang, awal bismillah pembuka bicara. I welcome this day with all of you here today to a country full of charms and beating drums. Selamat datang to Malaysia, as we say, a place where you will be welcomed with open arms. Praise to the Almighty, we have been graced by chance together in this momentous ceremony. Yang berbahagia Profesor Tan Sri Datuk Dr. Haji Muhammad Hanifah bin Haji Abdullah, Pro-Chancellor and Executive Chairman of MAHSA University. Yang berbahagia Profesor Datuk Ikram Shah bin Ismail, Vice-Chancellor MAHSA University. Yang berbahagia Professor Dr. Sri Kumar Chakravarti, Director of Postgraduate Studies, Research and Innovation, MAHSA University. Yang berbahagia Professor Datin Dr. Zoria Aziz, Conference Chairperson, Dean of Pharmacy, Faculty of Pharmacy, MAHSA University. Our guest of honor, Yang berbahagia Professor Dato Dr. Adiba binti Kamaruzaman, Professor of Medicine and Infectious Diseases, Faculty of Medicine, University of Malaya. Honorable speakers, Mi-PHARM Conference 2021, Organizing Committee, distinguished international and local participants, ladies and gentlemen. Salam Sejahtera, a very good morning. My name is Dr. Audrey Yong from the Faculty of Pharmacy. I am your host for today. It's my privilege and pleasure on behalf of the Mi-PHARM Conference 2021 Organizing Committee to welcome you here today. We are delighted to have you with us to participate and share in our Mi-PHARM Conference 2021 with the theme Changing Landscape in Pharmacy Practice, Adapting to the Needs of Tomorrow. Thank you for attending this virtual conference. Ladies and gentlemen, we will have a welcome address by my Dean, Professor Datin Dr. Zoria Aziz, Conference Chairperson, Dean of Pharmacy, Faculty of Pharmacy, MAHSA University. Please welcome Prof. Zoria.
Thank you, Dr. Audrey.
Thank you.
Our Honorable Executive Chairman, Tan Sri Hanifa, VC, Prof. Ikram, Director of Postgraduate Research, Prof. Sri Kumar, Prof. Adiba, the special guest speaker, plenary speakers, fellow pharmacists, and respected participants and audience. Assalamualaikum, good morning and welcome to the MAHSA International Pharmacy Conference series number 1, 2021. So we are actually fortunate to have with us this morning Prof. Adiba, a prominent infectious disease expert and highly respected figure nationally and internationally. She's a super duper busy professor, but still she can make time to be with us, to talk with us about living with COVID-19. So thank you so much, Prof. Adiba. So like many professions, pharmacy has developed over the years. So this has actually dramatically transformed our healthcare delivery. So against this background, we actually carefully bring together experts in the various fields of pharmacy to share the development in their respective areas. So they will share the challenges and opportunities available that will benefit the existing pharmacies and future pharmacists. That is, will be students, yeah? So over these 2 days conference, the plenary lectures and panel discussion will cover 6 pharmacy areas. So the first one will be hospital service. So Puan Fuzia Abdul Rashid, she will present a wide range of innovative ways pharmacy deliver its various services in the hospital and in the Ministry of Health. So the second area will be research and publication. So now pharmacists are expected to do research and publish their findings. So as editor-in-chief of the Journal of Clinical Pharmacy and Therapeutics, Prof. Elaine will give us a glimpse into the world of publication. So Prof. Elaine will be speaking at the end of today because he's speaking from UK and he will be on at 4 o'clock our time. Yeah, so that will be 9 o'clock UK time. The third area will be the role of clinical pharmacists has expanded in Malaysia. So Dr. Rahela will take us through how clinical pharmacists actually can move from having basic competencies to be an expert practitioners. Just for your information, in Malaysia, there are there are only 3 pharmacists who are subject expert, and she is one of them. Yeah. The fourth area will be cosmetics. Cosmetics are very popular in Malaysia, and our Indonesian academic collaborator, Lia Augustina, will share with us what are the recent development of protein-based cosmetics. So the fifth area will be the new role of pharmacists in science communication. So this is very new. So Dr. Yvonne will share with us what it takes to be a science communicator. And the last one, which is very important, pharmaceutical industry. So what are the opportunities for pharmacists in the pharmaceutical industry? So we have actually lined up 3 very experienced pharmacists from the industry. They are from Pharma Niaga to discuss these opportunities. Yeah, so our students, please listen carefully to what are the opportunities available for you in the pharmaceutical industry. So we have also slot for scientific presentation. Participants will do oral or poster presentation that showcase research from across discipline that highlight the collaborative nature of pharmacy research. So the diverse subject will illustrate the diverse activities of the profession. Okay, lastly, to the organizing committee, my work colleagues, I am actually very fortunate to have a great team, and thank you for all the hard work and support in organizing this conference. To the participants who have registered with us, thank you for all for your presence in the conference. So I sincerely hope you all will enjoy the presentation and discussion and have a fruitful conference. Thank you.
Thank you, Prof, for the warm welcome and introductions of all the speakers. We are now going to call upon Professor Dr. Sri Kumar Chakravarti, Director of Postgraduate Studies, Research and Innovation at MAHSA University. Please welcome Prof. Sri to give his opening speech.
Good morning, and thank you, Prof. Audrey. Thank you, Datin Prof. Zoria, respected Dato Vice Chancellor, respected Tan Sri Hanifa, and all the participants. Now, I understand that today about more than 100 of participants are students. So for the students listening out there, had this been a face-to-face conference, you all would have had to come here to Sarjana Putra campus. Now, assume that this was a face-to-face conference and you had to come here this morning. All of you would have taken the highway. And when you took the highway, you would have wanted to reach this place in the shortest distance possible or the fastest time possible, and you would have checked your Waze or Google Maps. But by the time you come to the roundabout, your Waze would have told you that you'll have to change your route because the roundabout has got a traffic jam and you would be delayed. So when the road conditions change, you check your road map to go to your destination, which is Sarjana Putra. The same thing is the destination for the conference. We are changing the landscape in pharmacy practice. So in order to accept the needs for tomorrow, which is the theme for this conference today, you have to change your landscape. And as much as your conference theme is on pharmacy practice, there are topics on pharmacy industry, topics in research and everything. In other words, what this conference means to say is that as your opportunities change, you will have to change your targets. You will have to change the way you go as well. And gone are the days when we had second, third generation drugs to treat diseases. Now we are in the fifth and sixth generation drugs. Even for cancer, we have targeted therapies. New therapeutic approaches and technologies are being done. And the main reason why we have to change landscape is after COVID, pharmacy practice has moved online. In Malaysia, sources say that 35% of sales in drug industry and pharmaceutical industry is online. And city pharmacies are operating through Grab, Lazada, Shopee. So, which makes us wonder as students that studying the curriculum alone is not important. We need to go a little bit further into entrepreneurship skills and how to learn to plan, practice, how to choose the industry. Now, you are all in this field for the past 1 or 2 or 3 or 4 years. And do you know what is the growth in the pharmaceutical industry? It is estimated that in the next 5 years, the pharmaceutical industry would grow by about 3 to 6%. Is that good or is that not good? Considering that the pharmaceutical industry is going to grow by 6% in the next 5 years, if you compare it with cryptocurrency like Bitcoin, Ethereum, Ripple, and all, that would grow 500% in the next 5 years. So it is easier investing money in cryptocurrency rather than investing money in the pharmaceutical industry, right? I mean, that's what people who want money think. But as Franklin Roosevelt has said, happiness is not just possessing money, it is in the joy of achievement, the thrill of being creative in what you do. And you guys have joined this course, so you're creative about being a pharmacist or going into the pharmaceutical industry. So make sure that what you have chosen, you just do it with love and passion, and you can go on to become something big in the industry. You can change the landscape for tomorrow so that tomorrow is a better place for you and the pharmacists who are junior to you and further on. Now, let me play the devil's advocate. As much as I told you that the industry would increase 3 to 6% in 5 years, the US drug industry says that they forecast that right now the pharmacy industry sale is 240 million US dollars. It could go up to 550 million US dollars, which is more than double. So the industry is set to advance. The industry is set to make more money. It is where you place yourself at the right moment that matters. And for this, you have to face challenges. And the challenges include changing yourself, adapting to the needs of tomorrow. And that includes like pharmacies. Now, pharmaceutical industry has advanced delivery systems, handling the challenges of the regulatory framework, and so on. I have a colleague, a research colleague in Indonesia in the pharmaceutical industry. He told me that his pharmaceutical company was doing research on PDL1, platelet derived ligand 1. And they were using new drug delivery systems, nanoparticles, to deliver the drug for cancer. But they put in millions of dollars and it did not work. So at that point in time, the company had to face failure. But luckily, for many smaller companies, drug research and bringing a drug to market is not viable because the costs are high. And you need to have multidisciplinary teams, and ethics is also involved. So you may need to have a company or be in a company or work with a company that has 10 different drugs which are under production, so that if 1 or 2 fail, the other 6 or 7 are successful. This is exactly what is the business model in KFC. KFC has hundreds of outlets. Even if a few outlets don't run, the rest of the outlets rake in profits. Anyway, the other aspect about KFC, as you all know, is Colonel Sanders started selling chicken at the age of 40. And he was rejected 1009 times until the 1010th time his business model was accepted. And now there's no stopping them. And I'm sure it's the same with all of us. So, students, participants, local, international, and respected members, I can see that today's scientific conference has very interesting programs, and we are keeping abreast with the developments on how to change the landscape. As much as the theme says pharmacy practice, we also talk about pharmaceutical industry and research, as Datin Prof. Zoria has said. And I extend my heartiest congratulations to all the members in the organizing committee in pharmacy, and also Max and also MAHSA for all their work. And lastly, I would thank you all for participating in this conference, and I extend a warm welcome to all the local international participants and also the students. And I look forward to sitting back and listening to the proceedings of the day. Thank you so much and have a nice day.
Thank you, Prof. Sri, for a very interesting and insightful opening speech. I would like to now welcome the Vice Chancellor of MAHSA University, Professor Datuk Dr. Ikram Shah bin Ismail, with a special address. Please welcome Professor Datuk Dr. Ikram. Good morning, Datuk.
Good morning. Thank you, Audrey. And good morning to everyone, especially to Tansi. It is a great pleasure for me to welcome all of you today at the MAHSA International Pharmacy Conference 2021 with the theme Adapting to the Needs of Tomorrow, following the changing landscape in pharmacy practice. Pharmacy profession has developed over the years from its conventional drug-focused task to include an advanced patient-focused approach. This advancement in the role of pharmacists calls for them to be part of the broader healthcare team, working to provide better healthcare for the patients, thus contributing to achieving the global development goals. The COVID-19 pandemic of 2020 has brought forward the challenges of an overwhelmed healthcare system. Throughout this conference, we will have a parallel research oral and poster presentation sessions, plenary talks, and panel discussions that will allow us to have an insight on what is best to do in adapting to the new changes in pharmacy practice. It is an honor for MAHSA University to have distinguished keynote and plenary speakers, as well as presenters from around the world, to share findings and knowledge at this international conference. I trust this conference will provide a great opportunity for all pharmacists, educators, and students to expand and update their knowledge in pharmaceutical sciences and related technology. I hope everyone will take this golden opportunity to network virtually and create new knowledge and knowledge centers leading to excellence in education and research in pharmaceutical sciences that ultimately benefit the community at large. I wish you all the best and hope you all have a pleasant conference session for these 2 days. And finally, I would like to congratulate the organizing committee under the able leadership of Professor Dr. Zoria Aziz, Dean of Faculty of Pharmacy, and Mr. Muhammad Kamar as organizing secretary for organizing this excellent conference. I sincerely hope you all will enjoy the presentations, discussion, and networking. And thank you and have a fruitful conference.
Thank you very much, Datuk Ikram, for the special address. We have come to the highlight of today's event, and without further ado, it gives us great honor to now invite Yang Berbahagia Professor Tan Sri Datuk Dr. Haji Muhammad Hanifah bin Haji Abdullah, the Pro-Chancellor and Executive Chairman of MAHSA University, to give us the inaugural speech and thereafter officiate the inauguration of MAHSA International Pharmacy Conference 2021. Welcome, Tan Sri Hanifah.
Distinguished guests, ladies and gentlemen, it gives me great pleasure to warmly welcome all the participants and speakers to the MAHSA International Pharmacy Conference 2021. With the theme, Changing the Landscape in Pharmacy Practice, Adapting to the Needs of Tomorrow. MAHSA International Pharmacy Conference aims to explore the changes in different roles of pharmacists required to meet the societal needs of the 21st century. This provides an excellent opportunity for the local and international academicians, pharmacists, and pharmacy students, especially in MAHSA University, to disseminate the research findings and share recent insights in the fascinating world of pharmacy and its contribution to the recovery of the COVID-19 pandemic. Our special guest, Dato Professor Dr. Adiba Kamal Saman from University of Malaya, will focus on the reality of managing outbreaks and the lessons that local policymakers should learn from the outbreaks. Over the next 2 days, we invite you to deliberate and explore developments and scientific advancements in various aspects of pharmacy discipline during the conference symposia, plenary lectures, and scientific communication sessions that has been carefully planned. MAHSA University will continue to play a significant role in developing the competitive workforce which is equipped with research skills and is able to transform their knowledge into practice. I do hope that participants will leave with the satisfaction of having collected new information, ideas, and skills. Finally, I would like to record my sincere appreciation to the Dean of Faculty of Pharmacy, Professor Datin Dr. Zoria, all presenters, plenary speakers, and Faculty of Pharmacy, MAHSA University for organizing the conference. I would now like to declare the MAHSA International Pharmacy Conference 2021 open. Thank you.
Okay. Ladies and gentlemen, we will play the MAHSA song now.
Di sini kita warnai kehidupan, menggapai cita, mengotakkan impian. Kita sang juara, peneraju cemerlang, perintis laluan gemilang, aspirasi negara dijulang. Semaikan keyakinan seluruh warga, kita mantapkan jaringan antara bangsa. Di sini lahirnya profesional berjaya. Kitalah wira di pentas dunia. University MAHSA, lambang kejayaan. University MAHSA, satu kemegahan. University MAHSA, menuju kemasyhuran. University MAHSA, pasti pilihan. Berdaya saing, berinovatif, berdedikasi, berintegriti, melahirkan insan berkualiti. Bangsa jadikan satu realiti.
What a beautiful MAHSA song. Thank you very much, Tan Sri, for your word of wisdoms and encouragement and for the inauguration of our conference. While waiting for the special talk by our guest of honor, we will sit down and relax and watch some videos. Thank you. Now we are all set for the special talk by our guest of honor, Datuk Prof. Dr. Adiba binti Kamaruzaman, Professor of Medicine and Infectious Diseases, Faculty of Medicine at the University of Malaya. Prof. Adiba graduated from Monash University in 1987 and trained in internal medicine and infectious disease at the Monash Medical Centre and Fairfield Infectious Diseases Hospital, Melbourne, Australia. Prof. Adiba was the former Dean of University of Malaya, Faculty of Medicine, the first female to hold that position in the institution's history. Professor Adiba is also the first Asian to serve as president of the International AIDS Society, IAS. In April 2021, she was appointed a member of the World Health Organization's Science Council, a select group that advises on scientific and technological advances impacting public health globally. She established the Center of Excellence for Research on AIDS, CHERIA, that conducts multidisciplinary research on HIV, ranging from clinical to public health and policy research. Prof. Adiba has used her clinical and academic leadership to engage in the national and community response to HIV/AIDS. She is currently chairman of the Malaysian AIDS Foundation and executive council member of Malaysian AIDS Council, the peak HIV NGO in Malaysia. Prof. Adiba is presently an executive council member of the International AIDS Society and a member of the UN AIDS Scientific Expert Panel on HIV. She has also been an advisor to numerous WHO committees on HIV/AIDS. She has played a key role in establishment and ongoing activities and collaboration of regional HIV research network initiative, Treat Asia. Her achievement has been recognized through several national and international awards, including the Tun Mahathir Science and the Merdeka Awards for her role as a member of the University of Malaya Nipah investigative team. She is the first recipient of the Advanced Australia Global Award in the category of alumni in 2012, and in April 2015, she was honored with a Doctor of Laws from her alma mater, Monash University. She also has the distinct honor of having been featured in both the Lancet and Science publication. Please sit back and be prepared to immerse in Adiba's special talk with the title Living with COVID-19. Good morning, Prof. Adiba.
Good morning, Dr. Audrey. Thank you so much for the kind introduction and for inviting me to speak this morning. When Prof. Zoria, very good friend of mine, invited me to speak today, she said, "You can speak on anything," and I thought, well, we will discuss probably the hottest topic at the moment, which is how are we going to live with COVID-19, having spent the last 2 years living rather unpleasantly with it, and very many lives lost, and very much suffering all around in the country. Now let me see. Okay, just bear with me while I share my slides. Can you see the slides now? Can you all see the slides? Okay, I'm assuming that you can. Okay, so the title of this morning's presentation is The New Reality of COVID-19, what everyone is talking about, endemicity, and how do we live with the virus. I just thought I'd spend a few minutes recapping, the events of the last 2 years, and really what has happened has been really unprecedented. The emergence of pneumonia, which was first reported in Wuhan in December of 2019, that quietly captured the attention of people like myself, as it began to be reported in ProMed and other newspapers in that region, slowly became a worldwide pandemic. Well, it wasn't that slow actually. By March of 2020, it became, as we all now know, a global pandemic. And the events since then, in terms of the rapidity by which it has spread, the global toll it has taken, and the economic devastation that it has created right around the world has been enormous, tremendous, and as is often heard, unprecedented. At last count, the official global COVID-19 death toll is approximately 5.1 million, but The Economist, the well-respected publication, which has been tracking the deaths and have been doing modeling of the deaths due to COVID-19, estimates the global excess deaths as a result of COVID-19 to be somewhere around 10.7 million at a conservative estimate, or more likely to be 3 times that of the official death toll. So it's 17.3 million. So when you think about it, HIV/AIDS has been around for 4 decades now, and there's been 37 million deaths in recorded deaths in such a short time. In less than 2 years, COVID-19 has caused probably upwards of 5.1, but upwards of 10, if not 17 million deaths. So I think there has been no one in Malaysia who has not been touched by it in some way or other. I think each of us probably know someone who not only has been infected with COVID-19, but also unfortunately passed away from it. So we in Malaysia, I think it's not an understatement to say, have had a pretty traumatic and terrible time with the pandemic over the last couple of years. Just again, let me just recap the numbers. Sometimes it's quite easy to get numbed by the announcement of the numbers that we hear every day. Last year, if you all recall, we were all quite anxious when the numbers were in the 3 digits. But now, we kind of expect to hear numbers in the hundreds, if not in the thousands. So Malaysia has had more than 2.5 million cases, confirmed cases that we know of, and 29,000, so close to 30,000 people in Malaysia have died of COVID-19. Now, what is what is stark about these numbers is that of the 2.5 million cases that have been reported, more than 2.2 million, I think, have been just in this year alone, and predominantly between May and October of this year. Likewise with the deaths, as we know, the peak of it has been in 2021 from May onwards. Why is this so? Despite stringent restrictions and MCOs and MCO after MCO, in this publication from my colleagues, Dr. Sanjay and others from the Department of Social and Preventive Medicine, that was just recently published in the Lancet Regional Health, Malaysia was not short of stringent, what is known as non-pharmaceutical intervention, including early border closure, international travel controls, early institution of widespread masking. Of course, we all know that we have had cancellation of mass gatherings, workplace closures, school closures, stay-at-home requirements for a long time. But despite all that, we have not emerged well from the pandemic, as was stated before, in terms of total number of infections, even if you correct that for the population, both incidence of cases and case fatality and mortality rates have been on the high side compared to our neighbors and other countries of equal or similar economic levels. Now, why did we suffer so badly? Why have we had such high incidence and death rates? I think one word or one explanation would be our hospitals just completely became overwhelmed. It wasn't just our hospitals, but also our public health response just became overwhelmed when the Delta variant landed on our shores. Unfortunately, the highly infectious Delta, which became widespread around about May of this year, came at a time when we were just starting to escalate our vaccination program. And at least in the Greater Klang Valley, we were at 50% or less of vaccination coverage when the Delta virus really got going. As we know, compared to the original Wuhan variant, with Delta, one index case can go on to infect at least 6 to 7 other cases. And being the high density capital that and the Greater Klang Valley and Selangor in general are, the onslaught of Delta was just not able to be pulled back, even with the stringent MCOs, etc. I mean, I sometimes wonder if perhaps the order to stay home may have worsened things a little. I mean, this is purely speculation. In certain scenarios, for instance, in highly in high concentrated dwellings, for instance, the PPR flats, when you've got multi-generational families living together and 4, if not 8 people living in very tiny dwellings, that may have exacerbated the problem. So the one reason why cases just became uncontrollable was if I think some of you may have experienced this personally, that our PKDs, through no fault of theirs, it's largely again through chronic underinvestment in public health, the discipline, were no longer able to respond in terms of case notification, contact tracing and isolation within the stipulated 24 to 48 hours time frame, if you really want to cut the transmission of to limit the transmission of COVID-19, as their workload just became tremendous. And there was first of all, much of the work was done manually, and there were just not enough physical bodies to do the contact tracing. So instead of a 24, 48, at the very least 72-hour response time, in many situations, it dragged on to 4 to 7 days. So the cases were not able to be isolated and quarantined effectively, and hence, one case just escalated to another six, to another six, to another six, and that was the situation that we were in. So the hospitals became overwhelmed, which then led to less than ideal clinical care. Patients were very ill. We ran out of, at one point we were, almost reaching, or maybe we did for a few days reach the scenes that we heard about from India in terms of sharing oxygen tank, and we actually did run out of the immunomodulators like tocilizumab and ceritinib, the IL-6 inhibitors, and this led to an increase or higher than desired mortality rate. ICUs, which at the best of times are over capacity, it just also became very, very difficult to manage. So compared to other countries in the region with similar GDP, we unfortunately had higher death rates than should have been. In addition to the health and mortality toll, of course, all of you are familiar with the economic devastation, as well as other social impact that COVID-19 had as a result of the MCOs. So there's the white flag campaigns, the red flag campaigns, the suicide rates, and the struggle with providing education through online teaching, particularly for families that are may not have the luxury of laptops and rooms to run to for online teaching, and worst of all, the quality of broadband in many areas was not ideal for long distance learning and online learning. I think small and large businesses suffered greatly, including the hospitality industry, including and particularly travel and tourism, which is one of the biggest income earners for the country. Before I move on to the actual title of my topic, which is living with endemicity, I think it is important that we reflect the reason why we in Malaysia saw such a large number of cases, and it's not just from what I said in terms of the underinvestment in public health that led to our inability to respond quickly and more widely when we were faced with the Delta variant. But I think three groups of people suffered disproportionately from the virus, not just in terms of the death toll and economic impact, but from the sheer number of cases, like what I alluded to earlier, in terms of the high density living in places like the PPRs, whether it's in Kerinci or Taman Medan or other similar areas. This was actually highlighted by colleagues at the Khazanah Research Institute from early of last year, that COVID-19 is going to have a major impact on the urban poor for reasons of many many work as daily wages, and if they're not going to be able to work, then financially they're going to be heavily impacted. And secondly, in terms of food supply, once again, if there's going to be lockdown and they're not allowed to go out, food supply will be a problem, and access to affordable food. And number three, the living conditions. And I quote here, typical PPR in Kuala Lumpur consists of at least 316 units with average household size of 4.6, approximately 1,400, 1,500 people will be crammed all together in one building. And as now we know, that ventilation plays a huge role in terms of viral transmission. And the authors in this report says, therefore, the PPR flats are going to be perfect breeding ground for this novel coronavirus. I think more prophetic words had not been mentioned. And unfortunately, what these authors said here came true. And, we saw large number of families, entire families being impacted by the pandemic at the height of the problem between May and September of this year. So the urban poor were disproportionately affected. And of course, migrant workers, again, we knew that this was coming because Singapore had suffered from high rates of infection. If you recall, last year, around May of last year, and it stood to reason that we would see the same problem because of the poor living conditions, the cramped spaces, the poor hygiene, etc. And true enough, a significant proportion of the number of people who have been infected in Malaysia are the migrant workers. And more disturbingly, they make up a disproportionately high number of those who were brought in dead at the peak of the pandemic. Now, one of the struggles was in terms of providing vaccination when the rush to vaccinate as many people as possible. There were all these mixed messages. The Ministry of Health and the government in general were, of course, had agreed to vaccinate everyone. But there were also mixed messages with the immigrations and Ministry of Home Affairs that led to fear of being arrested and delays in terms of migrant workers coming forward to be tested. Eventually, they did, and I think we now have a good proportion of people who are vaccinated, and hence. From September, October onwards, we started seeing a decline in the number of new cases as the vaccination coverage approached 80% of the adult population. The third group that has suffered disproportionately is those in detention centers and prisons. If you recall, I guess the original outbreak, apart from the Petaling Tablik outbreak as in the first wave, the one that has created massive clusters was the one that originated in Sabah. Everyone blames the Sabah election to some extent, that's true, but the original cluster in Sabah actually originated from the detention centers in Sabah. And since then, there have been many clusters originating from the prisons. And in Parliament in September, the Deputy Minister for Home Affairs reported that more than 51,000 COVID-19 cases had been reported in Malaysian prisons. And when you consider the prison population at any time is about 70,000, this represents a huge proportion of people. This is not just prisoners, but also prison staff and prison and family members of staff that have been heavily impacted by the virus. So on to the focus of my presentation, or the main topic of my presentation, which is endemicity. How do we live with endemicity now that we have more than 90% of the adult population and close to and I think about 80% of the entire population being vaccinated, as the efforts to vaccinate the 12 and 17-year-olds going very, very well. We have started to see up until last couple of weeks, a decline in the number of cases and opening up of the economy, relaxation of the movements, intra-state travel has now been allowed, and things are starting to get back to normal. But of course, in the last couple of weeks, the numbers are starting to tick up again. And so it's a reminder that whilst we want to live with the virus in an endemic state, I think the worst is not over yet. So what do we mean by endemicity? And I think these words that we in the health sector use commonly have now been adopted by the general public and often may not be used in the right context. So bear with me as I just go through some definitions. Let's start with pandemic. Let's start with outbreak first, where you have increase in number of cases occurring above the usual levels, and this is something that we see from time to time. Let's say with cholera. I mean, there's been concern of cholera cases in the Petaling district just in this last week, but I don't think that constitutes an outbreak. I think there was only one case. But if it gets to 2 or more cases, then because cholera is rare, relatively rare, then that would constitute an outbreak. And then you've got an epidemic when that outbreak then spreads to a larger geographic area. And a good example of this would be the Zika virus, where the outbreak was thankfully confined, at least in recent times, to Latin America, to Brazil. The other pandemic that we're living at the moment, which has become endemic, is of course HIV/AIDS, the first pandemic in modern times, a health condition that has spread globally, and then endemic when that health condition then begins to occur at a steady rate amongst the population. So this is what we're aiming to do, moving from pandemic to endemic situation of the SARS-CoV-2 virus or COVID-19 infection. Now, what are the possible scenarios? I think in 2020, and certainly in the first half of this year, most of the countries around the world, and certainly in Malaysia, we were still going for the zero COVID goal, which was to completely eliminate COVID-19 from Malaysia, from the world, and the countries that were really going for this were countries like New Zealand, Australia, China, thinking that if we close the borders, we vaccinate people, we put in the movement control orders, that we would be able to eliminate the virus, which means no community transmission over a certain time period. Eradication means when you've done that for the entire world. The only disease that we've been able to eradicate globally is smallpox, we're working towards elimination of polio. And so I think the scenarios were going to be a mix of elimination and endemicity. There were going to be some countries that were still going to pursue elimination, or famously New Zealand and Australia and China, and Singapore. But even now, with the exception of China, all those other countries have declared that they will instead work towards towards endemicity, which means learning to accept that we will have persistent low-level community transmission with sporadic outbreaks seen in country. So how do we achieve that? By suppression, by vaccinating, and really having in place all those necessary measures. As we now starting to learn, vaccine, as fantastic as they are, is not the panacea, because we're starting to see breakthrough infections. So early on, the goal was to achieve herd immunity, meaning we vaccinate enough large number of people that for those who are not vaccinated, that we vaccinate a large number of people, we can exert a reduction in the transmission of cases, so that people who are not vaccinated will also be protected. So that's kind of the concept of herd immunity. But we now know that the herd immunity is difficult to achieve with COVID-19, because it would appear that the virus will continue, even with high levels of, will continue to propagate, and in fact, even with high levels of vaccination. The other concern about the SARS-CoV-2 vaccine is that it's not able to achieve sterilizing immunity, as we now know that immune response or immune protection starts to wane at about 8 months post-vaccination, 6 to 8 months post-vaccination. And it also depends on which vaccine has been given. So when enough people have gained some immunity through either vaccination or infection, preferably vaccination, the coronavirus will transition to what epidemiologists call endemic. It will not be, it's not likely that we can eliminate it, simply because it's highly infectious, and also because asymptomatic people can also transmit. So we often don't know who infected who. And for that reason, it's not easy to break the chain of transmission. But what we hope to achieve is fewer hospitalizations and fewer deaths, and by boosting the primary vaccine program, we hope to periodically re-up immunity, just as we're doing with influenza. And well, influenza is probably the most apt comparison when it comes to needing annual vaccination. So cases may continue to rise and fall in this scenario, perhaps seasonally, but the worst outcomes will be avoided. So probably the biggest achievement in the nation's pandemic response has been the procurement of vaccine and the amazing rollout of vaccine, so much that we've now got 98% adult vaccination coverage, and reaching 80-90% of total population coverage with the rapid rollout of vaccination to adolescents. So, but as you all are familiar with, there are still breakthroughs. So this is in the United States, and now we're seeing in Europe as well, cases are going up again. And by and large, the large number of cases that are being reported in Western Europe is amongst the unvaccinated. And certainly this is also the scenario in the United States, where you can see here The unvaccinated average weekly cases are 6 times higher than those who are fully vaccinated. And likewise, with deaths, those who are unvaccinated, it's 12 times as high compared to those who've been fully vaccinated. The situation in Malaysia in terms of breakthrough infections, we are seeing about 1.3 per 100 persons. The overall breakthrough infections of all categories in terms of category 1s to 5. And the kadar jangkitan is 5.2 to 5.3% in the first 4 months of the completion of the vaccination program. Now, in terms of severity, like I said, not all vaccines are equal. You need to take this percentage with a pinch of salt. I think these are raw data. Those who receive AstraZeneca, if you recall from the lottery, were largely younger people. So it's not surprising that those who receive AstraZeneca, there were fewer a higher risk reduction in terms of admission to ICU compared to Sinovac. Likewise, in terms of deaths. But since then, there have been other analysis which shows that the rate of severe disease is the protection against severe disease is best with the mRNA vaccines, followed by the adenovax vector vaccines, followed by the inactivated vaccines. So not all vaccines are equal in terms of efficacy to reduce severity and deaths. And then what about boosters? There's been a lot of messages going around, fear about mixing doses. In Malaysia, roughly 40% receive Sinovac, another 40% receive Pfizer, and the remainder through with AstraZeneca and other vaccines. So now that we're rolling out the booster doses, I think on a daily basis, I probably get between 2 to 5 inquiry. Is it safe to have a mixture of doses, as has been a mixture of vaccines, as has been announced by Minister of Health? And the answer is yes. Even in the primary vaccination, there was, albeit small, they weren't huge clinical trials, but what data there is, when I say huge clinical trials compared to the original clinical trials using homologous vaccines, but I personally am confident about vaccine, the heterologous strategy, and there have been enough, I think, clinical trials showing the superiority of mixing the vaccines because they're acting in different pathways. So these are vaccine boosters. How do they compare? So if you have Pfizer as your primary vaccination schedule, and you receive Moderna, you get 17.3 times increase in the BNAPs. If you have a homologous, it's about 15 times, and if your booster is with Janssen, it doesn't perform as well. And as you can see, it would appear that heterologous, such hard word to say, strategy is superior to using the same vaccine for your booster dose. Now, these are Western data, of course. Their primary initial vaccine have been largely either the mRNA vaccines or the adenovax vaccine, but studies are emerging both in clinical trials and laboratory as well as in real life data that the third dose, which is really what's needed for the Sinovac vaccine, again, the increase in neutralizing antibodies are better with is better with either the mRNA or other vaccines type, rather than being followed by a third dose of Sinovac. Now, the other reason that gives us hope that we can move to living with the virus and accept that it's going to be endemic around us, but with reduced severity in those who become infected, and reduced hospitalization and deaths, and prevent our hospitals from becoming overwhelmed again, is of course this exciting announcement of the effectiveness of two drugs. The first one was announced by Merck, the molnupiravir, that reduced the rate of hospitalization or death by 50%. And a more recent announcement by Pfizer of their drug that appeared to be even more impressive, that reduced risk of hospitalization or death by 89%. Now, I understand that Ministry of Health has put an order in for molnupiravir, and so hopefully that will be another arsenal or another tool in terms of managing the overall clinical pathway of patients with COVID-19. Now, for me, what's even more exciting is I know we've had to battle the cult of ivermectin, and I hope that obsession with ivermectin will soon go away. There is another drug that along the same lines, i.e., a repurposed drug like ivermectin for treatment of COVID-19, except I think that the science behind this is much, much more solid in terms of its mechanism of action as an anti-inflammatory and anti-platelet agent. And that drug is fluvoxamine, an antipsychiatric medication, SSR2, and which in several well-designed trials now have shown effectiveness in early treatment and reducing hospitalization and emergency care in patients. The beauty of fluvoxamine is there's been, it's a true and tried drug with minimal side effects. There are lots of drug-drug interactions, so you need to be careful in giving these drugs and be sure that patients are not on anticoagulants, etc., for instance. But by and large, it's a safe drug, and this is a recent publication in the Lancet Global Health, in a study that was done in Brazil, and prior to this, there's a study that was done in the US from a group from Washington University that shows its effectiveness. So I'm hoping to embark on a similar study. We're just waiting for ethics approval at PPUM. Aside from the underlying mechanism of action that makes sense, and it's safe, the other compelling reason to try fluvoxamine in a clinical trial setting is because the cost of this drug is going to be something like 10 ringgit per day. Molnupiravir, unless we get included in the recent announcement that Merck is allowing the drug to be manufactured by generic companies and be used in, I think, more than 90 countries. Unfortunately, as always, Malaysia was excluded because of our upper middle income bracket, according to the World Bank. The molnupiravir is probably going to cost us something like 1,200 ringgit per course, whereas fluvoxamine is going to be at 10 ringgit a day, that times 10 days of the treatment cost is going to be like 100 ringgit. So I'm very excited to do this study. Still looking for funding, but hopefully once ethics gives approval, we can go ahead and do this study as soon as possible with colleagues from the Ministry of Health. So in moving towards endemicity, there are several things that we need to do. We need to keep an eye on the variants. There is a consortium of scientists from Ministry of Health as well as academia that is tracking the variants that are isolated, or the SARS-CoV-2 virus that's isolated in Malaysia. We need to keep an eye on changes to variants, severity, transmissibility, breakthrough infections, very, very important. We need to, of course, keep an eye on the epidemiology itself, changes in severity based on age, comorbidity profile, and also impact that COVID-19 will have on patients chronically, and particularly long COVID. And then advances in treatment, like I just shared with you, how that can help shorten or reduce or even eliminate hospital stay altogether. So these are the things in terms of the health side that I think can help us transition into an endemic stage. And of course, the ensuring that everyone is vaccinated, and then we're all, looking at the decision to vaccinate children below the age of 11 or not. This is from the global sort of consultant McKinsey, and in terms of the overall, country approach to living with the virus or endemicity, there are four, they've suggested there are four interwoven imperatives. So number one is, of course, defining what that new normal is, and what we need to do, and which I believe the Ministry of Health is finalizing, is setting targets to define the new normal. It's extremely important that we have indicators and a matrix to see what that means. And there have been discussions around how do we what are the measures that we need to keep an eye on. Several of us have indicated that incidence rates, particularly, is not going to be, or daily number of cases is not going to be so relevant anymore. What's important is we keep an eye on not the overall total number of cases daily, but the number of cases of severe cases, so categories 3 and above. I think that would be an important number to track. Number 2 would be the ICU utilization from COVID, and overall hospital bed utilization from COVID would be another important indicator in terms of moving of living or the endemicity, so that we then can track the progression of the pandemic. The third would be death rates, obviously. And some of us have suggested that a fourth good indicator of whether the system is starting to get overwhelmed again would be the turnaround time from a case notification to isolation. So those are the things, at least from a public health perspective, the measures that we need to have in place so that when the numbers go up against those indicators that we've chosen, perhaps it would be time to pull back a little bit on some of the restrictions. Now, I think nobody, whether any of us individually or the government, is going to be prepared to have national lockdowns again. As can be seen in Europe, what they're doing is localize restrictions, and in Austria, they doing that for unvaccinated people. I don't know if we are going to be moving towards that, and particularly since we have a high percentage of vaccination. So I think how we move would be to if let's say we have an outbreak and numbers go up beyond those that we've chosen as alert numbers, then it would be perhaps time for to restrict mass gathering, to restrict indoor dining, to restrict going to the gym, to maybe even consider temporary closure of schools. So those are the things that you would have to be prepared to adjust according to levels of infection. And to do this is hugely important that the tracking of the numbers and infection is done not just at the national level, but really ideally at the district level and certainly at the state level, so that we can impose a pullback on the restriction as quickly as possible, and as short as possible, and as localized as possible. So I think that would be the ideal situation. So it's very important that we track the progress through disease surveillance, and like I said, that tracking needs to be as granular as possible and at local a level as possible, so that and like I said, we need to define the thresholds to activate tightening of the public health policies, e.g. local lockdowns or travel restrictions. And if the best would be if we're able to use predictive analysis so that we anticipate increase in infections or further outbreaks, rather than reacting too late, which is often the case. And we know that this virus spreads very quickly. And this capability is already there in terms of doing predictive analysis to assist in decision making. So like I said, the overall idea as we live through endemicity, just as we have with dengue, is to limit the disease severity and death. And I've already outlined some of the things that we have in the tools that we have to do this. One thing that I think we must do better is in terms of the whole cascade from knowing that someone is positive to to isolation to home monitoring. That home monitoring component, I think, can be strengthened through involvement of general practitioners and private practitioners, so that if a person progresses, or if a person deteriorates, that we don't wait too late before sending them to hospital, because again, there's effective treatment like steroids and the IL-6 inhibitors, but they work best, and even monoclonal antibodies, which are a bit more expensive, but those things are available, but they work best if given early. So by employing this whole selection of tools that we already currently have, inshallah, I think we should be able to limit the disease severity and deaths and overall number of infections. And with that, plus the public health measures that we take, if there is a sudden surge of cases, hopefully we can limit the disease burden again and slow transmission. So in essence, those are that's a strategy that needs to be taken from, accurate, timely, transparent data at as local level as possible to that whole cascade of detection, notification, isolation, home monitoring, early admission to hospital if they progress, to early treatment with some of these new drugs, and certainly if they continue to progress, early treatment with dexamethasone and IL-6 inhibitors. So inshallah, I think we now have the ability to intervene at every stage, so that we don't get into the situation that we did back in May till September of this year. So overall, what does it mean to transition? Like I said, we have to develop criteria, we have to set threshold for breakthroughs, for outbreaks. And importantly, it needs to be a risk-based approach at the individual level. So we need to re-educate our population in terms of taking personal responsibility for our health. We need to educate the public, once again, how the virus is transmitted, the importance of ventilation, the heightened risk of being indoors compared to being outdoors. And so if there is a surge again of the infection, what are the things that you need to avoid? So obviously, if you're indoors, make sure you have adequate ventilation, wear a mask, distancing, all those things that you all know very, very well, and protect the elderly. So, if suddenly there is a huge number of cases in KL, again, even if the restaurants are allowed to be open, you yourself should take personal responsibility and decide, do I want to take the risk to go to the gym? Do I want to take the risk to go to a restaurant? And maybe not if the numbers in KL are up. You don't have to wait for the government to say we're closing down temporarily the restaurant. So I think that is essentially how we need to move forward, and for everyone to understand the importance of or how the disease is transmitted, why wearing a mask indoors, why ventilation is important, why going jogging and not wearing a mask is okay. So all those things, I think, are crucial, trivial as they may sound, but in bringing in ensuring that the numbers continue to remain low. On the government side, I think improving that whole cascade, like I said, the find, test, trace approach, making sure that as many people are vaccinated and receiving the right boosters, making test kits available. So this is another thing that I've not touched on until now, is that the test kits have now become more and more affordable, even if you're vaccinated but you develop symptoms that would suggest that it's COVID-19, do a rapid antigen test. If you wish, do a PCR and isolate yourself. So I think that would be the way to go moving forward. And then, of course, we've already talked about the public health and hospital systems that need, and as well as pre-hospital care system that need to be in place, so that we can all be assured that that if we become infected, if we progress, that someone will take care of us and send us to hospital as quickly as possible. So community empowerment is key: self-testing, self-isolation, self-quarantine, mental health, resilient, and of course border controls and such like. So this is my second final slide. What living with the virus means is compliance to SOPs, personal responsibility, self-risk assessment, awareness of local restrictions, vaccinated, and of course, maintaining a healthy lifestyle and mental health resilience. So, in terms of moving towards endemicity, I am quietly confident, but then again, I'm an optimistic person. I think although we're not going to achieve, a zero COVID situation, we will, I think, come to a level where we can learn to live with it at a level that's acceptable, because we now have, amazing vaccines. Although we're seeing protection waning, but booster doses have shown to really increase the level of protection once again. We already now have know of better treatment, both at the early stages as well as the late stage, severe stage of the disease. We have a testing strategy, including self-testing, and workplaces may choose to do weekly testing, schools, etc. If there's an increase in number of cases. Unfortunately, we're going to have to, I think, continue to wear masks, especially indoors, for some time yet, until the virus sort of wears itself out and starts to go away. And then, of course, in the short, mid, and long term, we really need to look at how all our buildings can be better ventilated. So, in other words, an endemic COVID-19 means finding a new tolerable way to live with this virus, with the support of all these strategies that we already have in place. So with that, once again, thank you very much for inviting me to speak this morning.
Thank you very much, Prof. Adiba, for sharing your prolific insights to living with COVID-19. Unfortunately, due to the short of time, we will not be able to take any questions. So now we would like to invite our Dean, Prof. Zoria, to present an e-certificate to our guest of honor, Prof. Adiba, as a token of appreciation.
Can I say a few words?
Yes, sure, Prof. Please go ahead.
Prof. Adiba, your depth of understanding of COVID-19 and your passion for the subject matter really came through. You actually glows, during your presentation. Okay, thank you so much for speaking at our conference, because we are really grateful for the time and effort you took, especially when you have a flight to catch immediately after this talk. Yeah, thank you so much. We really appreciate your
Thank
time.
you
So
for
super
inviting me.
duper busy. Thank you. So
Thank you.
now as a gesture of appreciation, where's the e-certificate, Audrey? Dr. Audrey
Yes.
is coming.
Yes.
So there will be an e-certificate for you. I think the physical
Thank you.
certificate,
Thank you so much.
the physical certificate will be sent to you. To
Lovely.
you, Prof. Adiba. When I see you next, I'll pass it to you.
Thank you. Thank you,
Yeah.
everyone. Enjoy your conference.
Yes, thanks.
Thank
Bye.
you, Prof.
Thank you.
Bye.
Bye.
Thank you, Prof. Zoria and Prof. Adiba. Distinguished guests, ladies and gentlemen, we have reached the end of the opening ceremony of the MAHSA International Pharmacy Conference 2021. The organizing committee wish to convey our heartfelt thanks to all our guests online and conference participants for joining us this morning. We will have a tea break and we'll be back for the first plenary talk at the dedicated Microsoft Team links. The link is already provided to all participants. See you in the next platform. Have a pleasant and fruitful conference. Bye for now.